but if that knowledge is not translated clinically, it's of no use. So remember, I request you during your training, every day, once all your day work is over, your rounds, OT, go to ward. Tomorrow's next day cases, all the images of that patient, be it CT or PET scan or MRI or whatever imaging is there, go down to radiology and sit and analyze them and learn from them. In your training of over 3 years, then you'll become excellent and you are a class apart surgical oncologist than others. So today we have a beautiful talk, understanding head and neck spaces, what every surgical oncologist need to know. Our very senior, radio diagnosis and radiology specialist, Dr. Diva Shah. She's a very senior and very renowned and excellent radiologist from HCG Cancer Center, Ahmedabad. Thank you very much, Diva, for accepting our invitation, and welcome, and over to you, please.
Very good morning to all of you. At the outset, I would like to thank Dr. Dushan Manlik, Dr. Somashekar sir, Dr. Kaustubh Patel sir for giving me, and the entire team of FHNO for giving me this wonderful opportunity. So today we will be discussing about understanding the head and neck spaces, radiological perspective and the surgical perspective. So we will be discussing various spaces with various case-based examples. I'll be showing some of the videos, and then we will be discussing about that particular case, and at the end we can take the question answers or whatever the queries you have. So to begin with, we all know that head and neck is although a small area, but it is comprising of various fascial boundaries, multiple neck spaces. It has glandular structures, fascias, muscles, vessels. Now everything is passing through skull base and up to the mediastinum. So the objectives of my talk are to understand the spatial relationships between spaces of the neck, to learn the anatomic boundaries on cross-sectional imaging of various spaces of the neck, to learn the contents of each spaces to guide the differential diagnosis. So whenever we encounter any neck mass, any patient who presents with the neck mass, what is the most important? So first is where it is lying. What can be the space of the origin? So by evaluating the epicenter of that particular mass and pattern of displacing of surrounding normal anatomic structures, which is very important, that what structures are being displaced by that mass. So first is the space of the origin, the most important. Then after knowing that space of the origin of that particular mass, the second question comes, what are the radiographic features of that lesion, of that mass lesion? And what are the normal anatomic content which are seen in that particular space? That is most important. The radiographic features, what is the lesion, what is the margin, how it is appearing on CT scan or on MRI or on PET CT scan, and then after combining this radiological feature, after knowing the anatomic space origin, we combine it with the clinical features. What are the clinical signs? What are the clinical examinations? And this is how we are being helpful. We are being path guider to surgeon, that what are the most likely differentials with particular prominent evidence-based reasons. So briefly we'll see the overview of the neck space. Now extracranial head and neck space, that is the most important landmark, is the hyoid bone. So the part of the neck which is above the hyoid bone and below the skull base, that becomes your suprahyoid neck spaces, while part of the neck which is below this hyoid bone, that becomes your infra-hyoid neck space. And there are spaces which runs from cranial to caudal, above the hyoid bone and below the hyoid bone also. So the hyoid bone is the most important landmark. Whenever you are seeing any cross-sectional imaging, please locate the hyoid bone first and see the skull base. So then you will come to know that are you dealing with supra-hyoid neck space or an infra-hyoid neck space. Okay, now first we will see the facial boundaries. We all know that the neck comprises of superficial and deep layer of cervical fascia. Now radiologically we cannot see this facial layers, but at least we can divide that the which which space is lying in which part of the facial boundaries. Fine. So this is a axial T2 weighted MRI image. This is the T2 weighted T1 weighted MR image. Here is the thyroid gland. Here are the muscles and these are the vessels. Fine. So you can see the red line which is passing anteriorly. So this is the superficial cervical fascia. Superficial cervical fascia is a very thin connective tissue that encloses the skin. Beneath the skin, mainly the platysma muscle. So here you can see this is the superficial cervical fascia. Second comes the deep cervical fascia, which is again divided into the superficial, the middle and the deep layer. So these are the three layers of the deep cervical fascia. Now superficial layer that encloses the sternocleidomastoid muscle. Here you can see this is the sternocleidomastoid muscle. This is the trapezius muscle and it also encloses the glandular structure and it extends superiorly from the skull base up to the up to the mediastinum. Then this is the middle layer. Now this middle layer of the deep cervical fascia that encloses the visceral, the pharyngeal mucosal space and the visceral space. Now the middle part is known as the visceral space because it encloses the major visceras, the trachea, the esophagus, the thyroid, parathyroid, and the third layer which you can see here as the purple line, this is the deep layer of deep cervical fascia. Here you can see that encloses the entire vertebral column and the perivertebral muscles. So this becomes your, here you can see the layers of the cervical fascia. Now the important structure here which we can see is the carotid sheath. So basically carotid sheath is, the sheath is made up of all three layers which comes together, that is the middle layer, the deep layer and the superficial layer of deep cervical fascia that extends from the skull base up to the aortic arch and that forms the carotid sheath. So this is the overview of the layers of the cervical fascia. So this is how you can see on MRI that how your superficial cervical fascia which encloses the platysma and the subcutaneous tissue, and this is the superficial layer of deep cervical fascia. This is how it is seen on MRI. Now, so the extracranial neck, as I said, which excludes the oral cavity, paranasal sinuses and the orbit, and it is divided by the hyoid bone into the supra and infra-hyoid neck spaces, and in the middle we have the pharyngeal mucosal space in the suprahyoid part and visceral space in the infrahyoid part. And we have a paired spaces in the suprahyoid neck spaces, that is pharyngeal, parapharyngeal space, masticator space and and the parotid space. So these are the paired spaces which we can see on a suprahyoid neck space, while there are spaces which runs from cranial to caudal into supra and infrahyoid compartment, which includes the carotid space, retropharyngeal space, perivertebral space, anterior and posterior cervical space. So this is the overview of the anatomical spaces of the supra and infrahyoid neck spaces. Now first let's see this video which is running from caudal to cranial of a axial post contrast CT scan, and we can first identify the structures on this video clip. So I'm running the video now. So we are going caudal to cranial. So this is the lowermost part of the neck. Here we can see this is the trachea. Posteriorly there is the esophagus, and this is the thyroid gland. Anteriorly there are strap muscles. Again this is the jugular and the carotid which has started. So basically this becomes your middle layer. The middle layer of the deep cervical fascia encloses this visceral space. This is the carotid sheath. Again this is the posterior cervical space here, which you can see as we move cranially. Here you can see that this is the, again this is the cricoid and this is the thyroid. So here this is a part of the visceral space and pharyngeal mucosal space. We are going cranial, and here this comes the hyoid bone here. So hyoid bone is the very important landmark. As we go up here, we are now entering into the suprahyoid neck spaces, and that includes the middle part is the pharyngeal mucosal space, and laterally there is a paired space, that is both the sides. The symmetry, to see this symmetry is very important on axial scans. So this is the masticator space here. This is the parotid space, which is similar, and the lateral most deep cervical space. Again this is the perivertebral space which runs from cranial to caudal, and this is the parapharyngeal space. This is the parapharyngeal space. So parapharyngeal space is the crescent shaped space which you can see here, which is abundantly made up of the fat here. So fat appears hypodense on CT scan and hyperintense, that is bright, on T1 and T2 weighted MRI. And as we go up here, we can see again the part of the masticator space, which is suprazygomatic part of the masticator space. This is retroantral fat. Fine. So this is the overview of the various neck spaces on contrast enhanced CT scan. Fine. So now coming to case number 1, this is the axial T2 weighted MRI, and we are going cranial to caudal. Please see carefully. So whenever you are evaluating the lesion in head and neck, please see lesion first, and then most importantly try to find out the epicenter, whether it is above the hyoid or below hyoid. Then the next comes, please compare on the contralateral side what is happening on the normal side. So you will be able to see that where is the displacement of the normal fat planes or the anatomic boundaries. So let's see. Here we are going caudally, and we are going again caudally. Yes. So this is the level. Here we can see that something is happening here. So this is above the hyoid bone. There is a altered signal intensity lesion which we can see here, and again there is nothing here on this side. So we are going more caudal. So the lesion is seen in the parapharyngeal space. So how will we approach to the diagnosis? So first is, what is happening here? There is a widening of the stylomandibular canal, and there is a displacement, medial displacement of the parapharyngeal space. White, you can see here the white line. This is medially displaced. Now the radiological feature of the lesion. The lesion is not showing restriction on diffusion. most of the malignant lesions will show a restriction on the diffusion weighted images. Then this is the contrast characteristic of the lesion. That lesion is showing very gradual enhancement on post contrast T1 weighted fat saturated images. So this, the final diagnosis is pleomorphic adenoma, benign salivary gland to form the minor salivary gland rest in the parapharyngeal space. So here the important anatomical clue is whenever we combine the center of the mass lesion and the displacement of the parapharyngeal fat, which yields the strong impression of the space of the origin of supra-hyoid neck mass lesion. So here the mass is displacing the fat medially. So now the pre-styloid parapharyngeal space, this is a crescent shaped space as we have seen on the CT scan, which extends from skull base to the superior cornu of the hyoid bone, and inferiorly it is continuous with the submandibular space. Superiorly it aborts the petrous apex, no extension into the skull base foramina. This is also very important. This is how you can see on your MRI and on CT scan the pre-styloid parapharyngeal space. The contents we all are aware of, that it is basically made up of a fat. As I said, how does it look on CT and MR? It has a pharyngeal venous plexus, minor salivary gland rest, crescent shaped fat density on CT scan, and hyperintense on T1 and T2 weighted images. Now important thing here, as the PPS empties inferiorly into the submandibular space, so any infection or malignancy spread, you will see the spread inferiorly from the suprahyoid neck spaces into the up to the angle of the mandible. So please try to look all two spaces continuously whenever you are seeing any lesion into the pre-styloid parapharyngeal space. Now this is very important for all of us. The displacement of the pre-styloid parapharyngeal space, the displacement will give a clue that what is the space of the origin of that particular lesion. So if there is a lesion which is arising from pharyngeal mucosal space, it displaces the or it pushes the PPS laterally. If the lesion arises from the masticator space, it pushes the PPS posteriorly. If the lesion arises from the parotid gland, it pushes the PPS medially, and the carotid space lesion pushes the PPS anteriorly, while lateral retropharyngeal space or the node, if there is an enlarged node of the retropharyngeal space, that pushes the PPS anterolaterally. So please keep it in the mind. This is very important, and it will give us a clue the space of the origin of the lesion. Coming to the next case. So this is the axial T2 weighted MRI. We are going cranial to caudal. We are moving down now. So now look at where we are seeing the lesion. Okay, we are going down. So yes, we are seeing some abnormality in the region of foramen oval, and on left side we are seeing the multilobulated lesion which is seen here in the parapharyngeal space. It is also involving the masticator space, deep lobe of the parotid gland. We are going caudally, and it is nearly reaching up to the origin of the, just up to the submandibular gland. And this is the coronal view of the same patient, T2 weighted MRI. We can see the tumor which is multilobulated, but it is a dumbbell shape. Yes, here. And it is, and it is extending up to the foramen oval and causes widening of the foramen oval. So now how will I approach to the diagnosis? Before that, we will see the radiological characteristic. It is showing the restriction, which is that the lesion likely to be a malignant lesion. It is showing heterogeneous contrast enhancement with multiple cystic areas and widening of the foramen oval. Here you can see, and then extension up to the foramen oval. So the differentials could be a Naushit tumor, or it can be a rhabdomyosarcoma or spindle cell tumor paraganglioma. So here the approach of the diagnosis, first of all, lesion is showing cystic areas. It is causing widening of the foramen oval, means it is arising from the structure which is passing through the foramen oval. It is lobulated dumbbell shape. So this is nothing but this is a nerve sheath tumor of the arising from the mandibular nerve of the left trigeminal nerve, and importantly it is causing posterior and inferior displacement of the PPS. Now we can come to know that it is arising from the masticator space. So final diagnosis could come as malignant nerve sheath tumor of the mandibular nerve in masticator space. So again we are revising, combining the center of the mass lesion and PPS displacement will give us a clue of the space of the origin of the mass lesion. So now what is this masticator space? As the name suggests, it obviously the major contents are the muscles of the masticator space. Superiorly it extends from the foramen oval and spinosum. Inferiorly up to the inferior edge of the mandible. It has two parts, supra and infrazygomatic. And the contents we know: muscles of the masticator space, V3 branches, and inferior alveolar nerve, artery, posterior body of ramus of mandible, and TM joint. So how does it appear on MRI? So this is the masticator space. You have to see the muscles of the masticator space which appear dark on your MRI. This is the infrazygomatic portion of the masticator space. This is the coronal view. So whenever you want to evaluate the masticator space, try to see your coronal view, which is very important because all four muscles are seen well on your coronal view. You can see this is the medial pterygoid, the lateral pterygoid, and the masseter and the zygomatic and the temporalis muscle. So all four muscles are seen well here on your coronal T2-weighted MRI. Here this is the boundary of the masticator space, and this is the suprazygomatic portion of the masticator space where you can see the part of the lateral pterygoid muscle and the temporalis muscle. So these are the two parts which we need to remember, and the coronal view, which is important. We all know that most common abnormality that we encountered in masticator space is infection. The odontogenic infection, always we should keep it in mind as the radiological differential diagnosis. But apart from it, as a surgical oncologist, the most important thing is the spread of the tumor into the masticator space and the perineural spread, because it has a very critical importance in the staging and the prognostication of the various head and neck cancers. So this is, here you can see, this is the PET MR which we have done in our institute, and here you can see that there is a significant thickening of the entire mandibular nerve which is seen on right side, and it is showing FDG avidity. So this is let us look at the this is the case of the tumor here, the left buccal mucosa malignancy, and patient came for the staging of the tumor. And here we can see this is the axial post-contrast CT scan, and we can see where is the tumor. So here there is a bulky tumor which is involving the left buccal mucosa, and it is involving the deep buccal fat, but it is infiltrating the masseter muscle as well. And so the extent of this tumor, whether it is extending into the masticator space and what is the extent, is very important, and this is how we can see on our axial and the coronal. So this is the coronal image, T2 weighted image of the same patient. You can see the bulk of the tumor here, the upper and lower GV cell side, the deep buccal fat, and what is the extent of the tumor. So the coronal view is very important, as I said. So here we are not able to see the tumor in the suprazygomatic masticator space. So this is how we can see. This is the PET MR of the same patient. You can see the left deep buccal mucosa lesion which is extending up to the infrazygomatic or infranotch masticator space. So on radiologically, how we can see this infra-notch and supra-notch level. So here we have to do the oblique coronal. So always talk to your radiologist that show me the oblique coronal of the your CT scan, and then a line which passes through the mandibular notch. Here you can see the line which passes through the mandibular notch. So whenever you see your tumor which is extending above this mandibular notch, then it becomes your supra-notch involvement of the masticator space, while if the tumor which is restricted below this line, that becomes the infra-notch involvement of the tumor. And this is the very, very beautiful article which has been published, and this is how the infra-notch and supra-notch division is important. And in that particular scenario, both are T4B, but infra-notch disease is resectable, and in supra-notch we have to critically see about the involvement of the pterygopalatine fossa, pterygomaxillary fissure, and involvement of the foramina. And if there is only lateral part of the supra-notch is involved, then the disease is still resectable. Coming to the third case, again we are dealing with the parapharyngeal space tumor, which is seen on right side. Here you have a axial T1 weighted and T2 weighted MRI, and you can see that dumbbell shaped, very well circumscribed tumor which appears hyperintense on your T2 weighted images, and it is not showing restriction. It appears bright white on the ADC map. And look at the contrast enhancement characteristic, that the tumor is showing the gradual enhancement, and then on the delayed scan it is filling homogeneously with cystic areas within. Then what this can be? It is seen partly involving the deep lobe of the parotid gland also. So now what will be our approach of diagnosis? So this is a pleomorphic adenoma of deep lobe of parotid gland. So here what is important? What is happening here? So here we can see that there is a crescent shape medial displacement of the parapharyngeal space, and there is a widening of the stylomandibular tunnel. So whenever there is a widening of this tunnel and medial displacement, that means we are dealing with the tumor which is arising from the deep lobe of the parotid gland. So coming to the parotid space. So parotid space is again a lateral most space in the supra-hyoid neck space, and it is lined by the superficial layer of the deep cervical fascia. It extends from the skull base, that is stylomastoid foramen, and external auditory canal up to the angle of the mandible. As the name suggests, its major content is apart from the parotid gland, it has a fascial nerve, external carotid artery, retromandibular vein, and intraglandular nodes. So what are the landmarks on cross-sectional imaging which is important? The first is the superficial versus deep lobe. Now we know that anatomically there is no facial boundary that divides the gland into the deep and superficial lobe. But there are two things which is important, and that is how it can be divided. One is the parotid duct. So parotid duct, basically it is the ductal structure which emerges from the parotid substance, and on cross sectional you can see faint gray line which runs parallel to this masseter muscle here, and here you can see the opening of the parotid duct which is opposite to the left second molar upper molar teeth. So the duct which divides the gland into the two parts, the part of the glandular substance which lies medial and inner to this duct, that becomes your deep lobe, and this becomes your superficial lobe. Another important landmark is the fascio-venous plane of the patty, the plane which lies lateral to the retromandibular vein. So we arbitrarily draw the line which lies lateral to the retromandibular vein, and the part of the glandular structure which is inner, this becomes your deep lobe, while this becomes your superficial lobe. Then, as I said, the stylomandibular tunnel is again an important landmark. So always see this stylomandibular tunnel, which is posterior to this ramus of mandible and the styloid process. So whenever you see any lesion which causes the widening of this tunnel, and you can see there is a medial displacement of the fat plane, then your lesion is arising from the deep lobe of the parotid gland. Again, a very important landmark which should be always seen whenever you are dealing with the tumors of the parotid gland, that is stylomastoid foramen and stylomastoid canal. So this foramen, which you can see well on your axial thin CT scan, as here medial to the mastoid air cells and at the level of C2 arch of the vertebra, and always see whether there is any abnormal enhancement or thickening of the nerve, facial nerve, which you can see here or not. And the most importantly, it is well seen on your MRI. So parotid gland is the only salivary gland which contains the intraglandular nodes. 80% of the parotid gland tumors are benign, and out of 80% benign, the 80% are the pleomorphic adenoma. Clinical signs of facial nerve, we know that whenever there is a facial palsy clinical sign, it is in favor of malignant lesion. Now, what imaging investigation is most important whenever you are dealing with parotid gland tumor? It is MRI. So always do a post contrast MRI. Try to look for the nerve involvement on your sagittal. Here you can see that there is a parotid gland tumor, there is a metastatic node, and there is a thickening of the facial nerve. Here you can see in the stylomastoid foramen, and so this you can see well on your post contrast T1 weighted fat saturated MR imaging. And also you can see the auriculotemporal nerve which runs posterior to the ramus of the mandible, and you can see the thickening of this nerve also if there is an involvement of the auriculotemporal nerve. So try to talk and try to see these two nerves on your post contrast T1 weighted MRI. Coming to the pharyngeal mucosal space, so basically this space which extends from skull base to upper esophagus, it abuts the foramen lacerum and the clivus. As we know that the contents are mucosa and submucosa which extends cranially from nasopharynx, oropharynx, hypopharynx. Apart from it, it also includes the lymphoid tissue, minor salivary gland rest, and the muscles. Now here the role of the radiologist becomes the submucosal extent of the tumor, because most of the tumors are very well seen by the surgical oncologist. So for us here, the important thing is to always communicate with the surgical oncologist that what is happening at the mucosal level, because they are very easily seen on your clinical examination. So our role becomes the root of the spread of this malignancies into the adjacent submucosal spaces and subsides, which is important to know. Now here we are commonly seeing multiple interpretation pitfalls whenever we are dealing with whenever we are seeing the lesions of the pharyngeal mucosal spaces. For example, there is a large adenoid which sometimes mimic as the tumor, or there is an asymmetric thickening of the pharyngeal recesses which is commonly seen. For example, here you can see that this is a contrast weighted MRI, and you can see that you are seeing some thickening of the this nasopharyngeal recess on the left side, while this is normal on the right side. So this asymmetries to look are very important, and importantly it is to address also that what is because this asymmetry can be physiological and it is sometimes overlooked, particularly in the treated patient. So this is the case of the female with the treated carcinoma of the nasopharynx, and she came to us with this type of asymmetry, and on MRI you can see that there is some thickening which is happening. We did the PET also of the same patient and we fused it. So this is the PET MR which is showing the uptake, typical here in this recess, and then the biopsy they took it from here, and it turned out to be a recurrent squamous cell carcinoma. So this asymmetry to addressed very carefully on the imaging by the radiologist, and please discuss together that what all this asymmetry is. This physiological, if there is any inflammation which is happening, or it is really we are dealing with the tumors. Coming to the another case, so this is the ultrasound image, which you can see that there is a very hourglass shaped cystic lesion, and in between there is a defect in the myelor. So basically this is the section of the submandibular space and the floor of mouth region. There is an hourglass shaped cystic lesion which is seen in the submandibular space and extending into the sublingual space also. And this is the contrast NN CT scan axial and coronal. We can see that yes, there is a very well defined smooth cystic lesion which is seen in the floor of the mouth and then extending into the submandibular space. So this is nothing but this is the plunging ranula. So sublingual and submandibular space, although they are partly a subsets of the oral cavity, I will not go into the detail of this subsets, but sublingual portion of which is a portion of the floor of the mouth, it is seen beneath the tongue and lateral to the mylohyoid muscle and superior to the submandibular space, while submandibular space is the horseshoe shape which is superiorly bounded by the mylohyoid muscle and inferiorly by the hyoid bone. So this is how it is seen on your MRI. So this becomes your sublingual space, which is the part of the floor of the mouth where you can see this sublingual gland. You have to always see that there is this is basically a shades of the gray on your MRI. So glandular structure will always appear little brighter than all the muscles here which you are seeing in the floor of the mouth. So this is the hyoglossus, this is the genioglossus. So the glandular structure will appear brighter on your MRI than the muscles, while this is your submandibular space and this is your submandibular gland. Coming to the infra-hyoid neck spaces, and the middle one is the visceral space which extends superiorly from the hyoid bone and inferiorly up to the superior mediastinum. Posteriorly, it is lined by the retropharyngeal space and laterally by the carotid space. We know this. And on cross-sectional imaging, now this infra-hyoid neck space, as is it contains the visceral spaces, the thyroid, the parathyroid, they are well seen on CT scan whenever we are dealing with the malignancies of the thyroid gland, or we want to see the parathyroid adenoma. Since these are the superficial structures, we can evaluate these spaces and these organs better on ultrasound and the CT scan. And the contents of the visceral space we know, that is hypopharynx, larynx, trachea, recurrent laryngeal nerve, pre and paratracheal nodes. Now coming to the next case, this is the contrast enhanced T1 weighted MRI. We are going cranial to caudal, and we are seeing that no, nothing is happening here up to the level of the hyoid bone. As we go down, yes, there is a lesion which is seen here, which is oval shaped lesion here in the region of the neck. It is extending primarily in the up to the hyoid level and primarily in the infra-hyoid neck space laterally. Now, what is the approach to the diagnosis? What are the differential diagnoses? Is it a carotid body tumor? Is it a vagal now schwannoma, vagal paraganglioma, or it is a sympathetic chain schwannoma? Because it is in the carotid sheath. So now approach can be, the lesion is very well defined. Now whenever we are seeing the lesion of the carotid sheath, what are the important structures lying and what is the situation of the vessels? Here there is no splaying of the vessels which is happening. So there is this is the ICA and this is the ECA. So it is not displaced, no splaying of the vessels, and IJV is displaced anterolaterally. Here you can see, you are not able to see any fluids within the lesion. So there is no splaying of the vessels are moving anteriorly, and even the IJV is also displaced anteriorly and anterolaterally. So what is happening here, that the structure in the carotid sheath which is lying posteriorly, the lesion arises from this structure which is displacing the vessels anteriorly, no phlovoids, so this is nothing but this is sympathetic chain schwannoma. So carotid space, as I said earlier, it is this space which extends from the skull base up to the aortic arch. Superiorly, it aborts the jugular foramen and all three layers of the fascia which we have seen previously that contribute the forming of the carotid sheath. Now contents which is very important here to know on imaging, that the suprahyoid and infrahyoid neck space, the content a little bit different, that in suprahyoid, apart from the carotid, internal jugular and all four nerves, sympathetic plexus, while in infrahyoid neck space it contains vagus, rest all nerve have exited. So this is very important. Again, coming to the sixth case, that there is a cystic non-enhancing lesion which is seen on right side. Now it is not involving the visceral space, not involving the carotid sheath, but it is lying posterior to this right internal jugular vein, and it is extending elongated on your coronal view. Here you can see the lobulated cystic lesion. So which space is this? First of all, try to see that this space on normal side, it is all the made up of a fat. Here you can see you are not able to see anything. It has a effaced fat plane with adjacent structures. This is the perivertebral space which you can see here. This is the sternocleidomastoid muscle. So what is this space? So this is nothing but this is the cystic lymphangioma which is arising from posterior cervical space. Now what is this posterior cervical space? Basically this is the space which is an inverted tent shape, tilting tent shaped space. So it is a small superior component. It is a triangular superior component which is seen at mastoid tip, and it is a broad inferior component at the base of the clavicle. That is how it form a tilting tent. Posterior boundary is sternocleidomastoid and anterior to the trapezius muscle, and it is deep to pericervical perivertebral muscle. So the content, as we have seen here, that it has a five supraclavicular nodes. Coming to the next space, that is retropharyngeal space. Now this space again is also important, but radiologically, if there is no pathology, we hardly see this space on the cross-sectional imaging. So first, anatomically, this space extends from the skull base up to the D3 level in mediastinum. And then how does it look on your cross-sectional imaging? So this is the retropharyngeal space, the green dot here you can see. So basically it is lying posterior to the pharyngeal mucosal space or the visceral space, and laterally there is a carotid space, and posteriorly there is a perivertebral space. So how does this appear on your cross-sectional imaging? any pathology from now how do you differentiate this this is the post excellent imaging. There is a one. There are multiple paper which has been published. Values, particularly when it is going more than 1.5, you do not need to do the FNA of that particular tumor, and can directly go ahead with the surgery also. So for parotid gland tumor, for skull base evaluation, for perineural spread, for parapharyngeal fat, all this for all this MRI is good. But
Thank you.
yeah, so
because in the only issue was claustrophobia, but in Bangalore we have an open MR console, so there is no new high-end MR, at least we have in Bangalore.